are not the primary treaters. The orthodontist is the primary treater, and we simply provide an aid to orthodontics to reduce the treatment time, to make movements which will be impossible without surgery and just using orthodontics, and to provide some anchorage, to provide segmental procedures, although there is a lot of morbidity of blood supply loss when we perform segmental procedures. And sometimes we can simultaneously put in implants to replace missing teeth, but only in the mandible, not in the maxilla, because that will compromise the blood supply. I would like to emphasize that it is always a team approach between the dentist or the prosthodontist and the orthodontist and the surgeon together. There is no role for each person doing their bit and then passing it on. It requires a plan as a group. We can use it to manage post-cleft deformity. Babies who have cleft palates repaired, their maxillas do not grow, and so we then have to surgically advance the maxilla after puberty. And also in the management of a structural success. As in all of medicine and dentistry, the first thing we look at is the presenting complaint. Is the patient concerned about function, or are they concerned about aesthetics? Maybe both. From the hairline to the glabella, to under the nose, subnasion, to submentum. And each of those thirds should be equal for vertical harmony. So we routinely, conventionally in the past, used lateral cephalometrics from the front with a frontal X-ray. And we look at symmetry, left is to right. Is there any canting or wrong angle of the smile? Where is the midline of the top jaw and the bottom jaw? And is that coincident with the face? And finally, the facial fits, divided into these fits to make it symmetric. All of that can be done with digital planning with a CT. We don't do this in the beginning because the CT has a big radiation dosage. So we will still use conventional planning with those X-rays in the beginning, but when we come to the CT and the STL file of the arches into the software, and we get this on how the arches fit together, we're going to talk to the orthodontist about what we need to do before the surgery to decompensate. So this person, decompensation with the orthodontics is happening to educate the patient about what's going to happen. Essentially, it will get worse before it gets better, because as the orthodontist proclines those teeth, the patient is going to start to lip trap, which is not a good look, and they need to know to expect that for a short period of time before we do the surgery. Between 2 and 4 days of hospitalization, about 10 days to 3 weeks on patient when they have finished growth, as late as they will be tolerated by the patient. But of course, if the patient has a problem, they are push us to treat early, and sometimes we need to resist that to get the best result. Less important with class 2 because they stop growing early. Less important with females because they stop growing early. But class 3 male, I don't like doing before 20, 25 because there are situations that we can do to affect various types of movement. Our workhorse in the mandible is the bilateral sagittal split osteotomy. The buccal cortex is split from the lingual cortex, usually exposing the nerve, so there is some numbness for a short period of time post-operatively, through the sigmoid notch, posterior to the nerve. The subapical, where we need to just move the incisor teeth, so if they are super erupted in class 2 div 1, we can take a section out here and move the section down. We can also do a split right through the symphysis to narrow the mandibular arch or to widen the mandibular arch to match the maxillary arch. It's the Lafore 1 osteotomy. So that is at the level of the nasal floor. As we can see not only the teeth and the papilla, but we can see the roots of every tooth as well, and it's not an attractive appearance. She has teeth, but she looks like she has dentures and left them out because she is overclosed. So we have, we have downgrafted her maxilla, so now when she smiles, we can actually see some teeth. But it's important in this one that we overdo by about 30%. And this is the 4-3 level, which is very high. This requires the bicoronal flap that Dr. Avia showed you. As well in the maxilla, we can expand with an orthodontic appliance. We can do a partial to 4-1 osteotomy, split the midline, and expand the point forwards. And we can do 2 layers, like bring the bottom forward, and then underneath that. So we've made an oblique cut, chin down to increase the height. It also goes back to reduce the prominence. This is a lady who has a pure vertical augmentation where we get a gap, so we can bone. And again, we can take that bone, not from the chin this time, because we're operating on the chin, but we can take it from the lateral mandible, and we can take it from other parts of the body, such as the iliac crest, or the skull, or wherever. Vertical reduction, this young lady had a very long chin, and it was making it difficult to get together, and now we've shortened it. And a midline shift, so this young lady has her chin off to the right side of the nose, and post-operatively it is straight, and it was also pointing downwards, and post-operatively it is parallel to her pupils. We always use the pupils as the baseline, because that is what everybody looks at. When you meet somebody, you look into their eyes, and your brain takes its reference from the eyes. Everything else has to be parallel to the eyes. We tend now to use plates rather than wire. I used to use a lot of resorbable plates, but that option is not available with digital planning. It's interesting, they can 3D print titanium, but they can't 3D print resorbable plates. And so I don't use as many as I used to. And we have very small plates as well. If we have areas which are non-structural, we, instead of using a 2 mil plate, we can use a 1.5, 1.3, or even a 1 mil plate, because we don't need the strength. We now have custom plates and custom cutting dies. So now I'm adding and custom plates, which are 3D printed from titanium. So this is my plan for the lady I showed you before. And this is the lateral that you've seen. It has, while she's having her CT, to hold her jaw in centric relation. And she already has a very, very deep submental fold. Her lip is rolled down by her other teeth because her mandible is protruded. And that's actually made a little bit worse by the putty bite, which is a problem, as you will see, because the software does not deal very well with soft tissue changes. We still have to use our own experience to know what's going to happen to the soft tissues. So this is moving her mandible forward simply to close the overjet. So here is the overjet. We digitally rotate the mandible up until the overbite is achieved, and then we will advance the mandible, and you can see they are now been advanced because there is no more overjet. But look what has happened to her aesthetics. I'm not too worried about the lip. When I'm consulting with a patient, I will put my finger or a pencil over that lip so they don't focus on it. Because this is purely the software not having the capability to predict the change. I know that lip's going to come up and recover when it's no longer rolled down by the top teeth, but the computer doesn't seem to understand that. Okay, but you can see that that chin is far too strong for a 16-year-old girl. And so I offer her the alternative of having her chin reduced backwards, and we can do the genioplasty in the software as well. So she has a certain If you take the putty bar out, she has a vertical lower third deficiency. She's short from here to here compared to other facial thirds. And so by setting the chin point back and sliding it backwards and downwards, we manage both problems. We increase the vertical height and we set the prominence backwards. And apart from the lips still looking terrible, we now have good balance of the nose, the top lip and the chin. And the bottom lip won't look like that after I finish her operation. It will look much better. We also get from the software exactly how far we are going to advance. So I now know I'm advanced. So intraoperatively I can measure that and I know that I have things in exactly the right positions. The software will also give us the measurements on the chin and if there's any counter correction and any rotation, as well as how far down and how far back. And then we get all the measurements that we know are going to happen. Magic X-ray. Trace it up or use something like dolphin. Use the angles of the mandible, and you can see I've got cutting guides here that fit along the occlusal braces. I always like a plan B. And I get a plate for the chin as well. So all of that comes to me from Germany. There are a few other things that I do which are totally independent of the bite. They're augmented, you saw in upper lip, without using fillers. This was way before Botox. So this is what cherubism looks like in the adult when it has results 3. So his maxilla went forward, mandible back, and the implants provided her post-operatively. TMJ pain, and there's a